Good evening. I'm Kim Burns. I am an oncology nurse practitioner at the Callaway Young Cancer Center, and I have specialized training in genetics. And I'm here to talk with everybody tonight about what is genetic testing. And I just want to remind participants that there's a Q&A button at the bottom of their screen, and you can just enter your questions there. And we will answer your questions when we have time. All right. So I just wanted to kind of start the talk with what is genetics? So genetics is the study of genes, and basically our bodies are made up of a bunch of cells, and in these cells are genes, which are made up of DNA, which are basically the blueprint for our body and tell our bodies what to do. And sometimes there are changes or variants in these genes that can cause a wide range of conditions in our bodies. And one of those conditions is cancer. So you'll hear changes in genes called different things. Sometimes they're called variants, sometimes they're called deletions or mutations or an abnormal gene. Sometimes changes in genes can be just in a tumor cell. So those kinds of changes are not able to be passed down to children or family members. For example, if there's a skin cancer, there might be genetic changes in that skin cancer, but it doesn't mean that you can pass it down to a family member. And sometimes changes in genes are throughout our whole body. And these changes can be passed down to children and can cause increased risk for cancer. So most cancer is sporadic or spontaneous. It happens from a multitude of factors. It happens from environmental exposures. Sometimes people are exposed to pesticides, infections like HPV, dietary factors, obesity, alcohol intake, smoking. Sometimes we see familial clusters of cancer. So that means that there is a lot of breast cancer in a family, but when we go to test for an abnormal gene or that it's hereditary, we can't find a hereditary cause. And we think that that could be due maybe to shared lifestyle factors, maybe a family of smokers or exposed to smoking, or shared environmental exposures, like I mentioned, pesticides or things like that. And then 5 to 10% of cancers are caused by are hereditary, and they're caused by an abnormal gene that's being passed from family member to family member. So as I mentioned, up to 10% of cancers can be hereditary or genetic. And sometimes that change can be what we call autosomal dominant. So that means one family member has a change in a gene or an abnormal gene, and they can pass it down to their family members. And when this happens, there's about a 50% chance with each child that the family member has that they can pass down this abnormal gene and that the child will have the condition. And when we're talking about this, we mean that the child would have increased risk for developing cancer over their lifetime. An example of this is the BRCA gene or the breast cancer gene. Sometimes hereditary cancers can be autosomal recessive. And what that means is that both parents have to be carriers, both parents have to carry an abnormal gene, both parents have to pass down that gene to the child for them to exhibit the condition. And that means that an example of that, sorry, is the MYUTH gene, which is a gene that's associated with having a bunch of polyps over your lifetime. So BRCA mutations, everybody has a BRCA gene, and BRCA genes fix basically broken DNA in the body. And When a person inherits a abnormal BRCA gene, that means that it's not functioning correctly to repair DNA and causes an increased risk for cancer. Women with an abnormal BRCA gene have an increased risk for breast cancer. They can have a 50 to 80% lifetime risk for getting breast cancer, whereas the average woman's risk for breast cancer is about 12%. They also have an increased risk for getting a second breast cancer once they've had a breast cancer. And they have an increased risk for developing ovarian cancer over their lifetime. 15 to 45% lifetime risk for developing ovarian cancer, whereas the average woman is about 1.3%. And there's also an increased risk for prostate cancer associated with the abnormal BRCA gene, increased risk for male breast cancer associated with an abnormal BRCA gene, pancreatic cancer, and not listed here, but melanoma can also be associated with the abnormal BRCA gene. And I wanted to mention with inherited breast cancer, it's not just BRCA anymore. This is a list of sorry about that. This is a list of a panel of genes that we test for now if we're concerned about a family having an inherited breast cancer. And so I've seen a lot of women who have had testing maybe 10 years ago for just the BRCA1 and BRCA2 gene, who now are qualifying for more updated and expanded testing. So when do we think about a family having possibly hereditary breast cancer? So one flag is an early age of diagnosis. In genetics, early age of diagnosis is under the age of 50. Also, Ashkenazi Jewish ancestry tends to have a higher risk for carrying a BRCA mutation. Breast cancer in both breasts. As I mentioned before, if a woman has an abnormal BRCA gene, if they have a breast cancer, they're at an increased risk for developing another breast cancer. So that's another red flag for a genetic component. Triple negative breast cancer or non-hormonal breast cancer. A male relative in the family with breast cancer is very rare for a man to develop breast cancer. So we think maybe there's a hereditary component when we see that in a family. Ovarian cancer, as I mentioned, there's a high risk for ovarian cancer with the BRCA mutation. And actually, in families with a family history of ovarian cancer, that alone qualifies a person for genetic testing. Pancreatic cancer. If a person has pancreatic cancer, they qualify for genetic testing, or if a person is a first-degree relative with a history of pancreatic cancer. And metastatic or high-risk prostate cancer is another red flag for a possible genetic component. And a combination of breast, prostate, ovarian, or pancreatic cancer in 3 or more relatives on one side of the family. So if, for example, a person has on their dad's side 2 aunts with breast cancer and an uncle with prostate cancer, that would be another flag for a possible hereditary component. And a known mutation in the family. I have seen some patients who come to me who know that their cousin tested positive for a BRCA mutation or a PALB2 mutation, and that qualifies a person to do genetic testing. I did want to mention, although this talk is focused on hereditary breast cancer, there's other hereditary cancer syndromes out there which can qualify a person for genetic testing or make a person consider doing genetic testing. One is something called Lynch syndrome, which is a hereditary cancer syndrome associated with high risk for colon and uterine or endometrial cancer, also small bowel cancers associated with that, and ureter cancer. So if a person in a family has a history of, for example, being diagnosed with both colon and endometrial cancer, that is a red flag for a hereditary component, or a family with 3 or more Lynch syndrome related cancers. So if on one side of the family there is 3 colon cancers or 2 colon cancers and a endometrial cancer in a family member, that's another flag for a hereditary component. There are some polyposis syndromes, which mean a person can get multiple colon polyps over their lifetime. So if anyone is aware of a family member with multiple colon polyps, and especially more than 10 polyps, that is another flag for a possible hereditary gene. And individuals diagnosed with kidney cancer under the age of 46. There are some hereditary kidney cancer syndromes out there. So how do we test for hereditary breast cancer? Sometimes you will see a provider and they will be set up to order the testing directly. But a lot of times a provider will refer you to a genetic professional like myself for a genetic cancer risk assessment or genetic counseling. And at this appointment, we take a detailed family history. We also take a personal medical history because that can play into some of this. And we discuss genetic information law and how that protects people against discrimination regarding genetic test results. Genetic testing is done by blood or saliva. And everybody asks me if they give us the same results. The only thing with saliva is sometimes the sample will fail and I'll have to have a person collect another sample, but the results will always report out the same. We talk about whether to do genetic testing panels, doing multiple genes, like I mentioned in that previous slide, all those different genes looking for hereditary breast cancer, or some people just want to look very specifically at certain genes. For example, if somebody knows in their family that there is a family history of a specific BRCA gene and they don't want more information, people will sometimes elect to do just single gene testing. We talk about insurance authorization, out-of-pocket costs. I do want to mention that genetic testing has become much more accessible and affordable. The out-of-pocket cost for most genetic testing with companies is $250, and companies offer pretty generous financial assistance to even help pay for that cost. And then if somebody elects to proceed with genetic testing, we meet to talk about the genetic test results. Results can come back positive, which means that a person has an abnormal gene that can increase their risk for developing cancer over their lifetime. It can come back totally negative. And then it can come back with this thing called a variant of uncertain significance. What that means is that there's a change on a gene, but we don't know if that gene, when it goes to be a blueprint in the body and tell the body what to do, we don't know if it actually causes any problems. And so we don't do much with those results. If a person's results come back negative, there is still things that we can do and things that we can look at. And like I talked about, sometimes there's those familial cancer clusters where there's a lot of breast cancer in a family, but we can't identify a gene that's kind of causing it. And what I'll do is I'll perform a breast cancer risk assessment. There's a couple models out there that can determine a person's risk for developing breast cancer over their lifetime. And we can still talk about personalized screening recommendations. Some women qualify for screening MRIs of their breasts. Some women, we do annual mammograms and ultrasounds. We also talk about lifestyle factors to reduce women's risk for breast cancer, regular exercise, maintaining a healthy weight, limiting alcohol intake. And we talk about medications to reduce women's risk for breast cancer. Now, if results come back positive, that somebody has an abnormal gene that we know increases their risk for getting certain types of cancer over their lifetime, there are things that we can do. Some women choose to have their breast preventatively moved. They choose to have all their breast tissue removed. Some women choose to have their ovaries removed if they're high risk for getting ovarian cancer over their lifetime. We talk about increased screening, because when we find out that somebody is at higher risk for getting certain types of cancer over their lifetime, we want to keep a closer eye on them than the average person. We do annual mammograms. Like I mentioned, sometimes we had ultrasounds. Sometimes people qualify for screening MRIs of their breast. We do breast exams at least once a year, sometimes every 6 months with your providers. And some women choose to do pelvic ultrasounds and CA-125s, which is a laboratory result to screen for ovarian cancer. Although most of the data out there has shown that it's not a great screening tool, but it is something that we talk about. And we, again, can talk about medications to reduce risk for breast cancer, ovarian cancer. Birth control pills have actually been shown to decrease women's risk for developing ovarian cancer. And again, those lifestyle factors, maintaining a healthy weight, regular exercise, a diet rich in fruits and vegetables, limiting alcohol intake, not smoking. Those things have been shown to decrease women's risk for developing breast cancer, even with a genetic abnormal gene, by up to 30%. So what can you do if you think you might be at risk for hereditary breast cancer, or your family has some of those things that we talked about that looks like possibly there could be a genetic component? Talk to your regular doctor. See if a genetic counseling referral or cancer risk assessment is appropriate for you, and consider genetic testing. So that is the official end of my talk. If anybody has any questions, I can take them, or we can email them after. Okay.
So we did have some questions. A lot of people have said thank you. That was a wonderful.
Oh, good. Thanks.
One of the questions was, why not screen everyone?
Yeah, that is a great question. You know, right now, genetics is changing rapidly, and there could be a time that we are screening everybody. But right now we follow these big national cancer guidelines, and they really say that we should screen families that are at risk. There is the question out there, if we start screening everybody, are we picking up things that we don't need to pick up, that maybe might never cause somebody a problem? So at this time, they're really saying we're screening people that look like they're at risk with their family history.
Okay.
Yeah.
Another question came up. If I had a genetic test and the result was negative, what could that possibly change in the future?
That's a great question. So at this time, if somebody's genetic test results are negative and they've had full genetic testing, because like I talked about, some people have negative genetic test results, but they were only tested for a couple genes. And now there's multiple other genes that we're testing for. But if we've done comprehensive genetic testing and it's negative, then it's negative at this time.
Okay.
Yeah.
And that was it.
All right.
Just
good.
love the presentation.
Great. Thanks everybody for joining. So please fill out the survey that you receive at the end of the presentation and let us know if you would like any other topics covered. And a link to the recording will be sent out tomorrow. So feel free to share with anybody who might be interested. And the next event is Wednesday, April 19th at 6. And radiation oncologist Dr. Rossi and breast surgeon Dr. Brew are going to be discussing survivorship and lifestyle recommendations.
We had a couple other last minute.
Okay, good, great.
Is genetic testing used for determining what type of medication to use for people that already have a breast cancer diagnosis?
These are great questions. So is genetic testing, can you repeat it? Is genetic
Yes.
testing used?
Used for determining what type of medication to use for people that already have a breast cancer diagnosis?
All right, so I'm going to repeat that. Is genetic testing used for determining what type of medication to use for people that already have a breast cancer diagnosis? The answer is yes. So, like I mentioned in one of those first slides, there's different types of genetics. There's genetics that can be passed down to family members, but there's also genetics in tumors. And so genetics in tumors can be tested. That's a separate type of genetic testing. That's not for hereditary cancer syndromes, but that genetic testing can sometimes be used to determine treatment plans.
Okay.
Yeah.
And then another great question. Do the results become part of a permanent medical file, and can insurance companies discriminate for health or life insurance for mutation?
Okay, I'm going to repeat that question. Do the results become part of the permanent medical file? Can insurance companies discriminate for health life insurance for mutations? Another great question. And this is a big reason why genetic counseling is so important. So there's a big genetic information law out there that protects people against losing their job, losing health insurance, but it doesn't protect against a couple things. And one of those is life insurance. So I talk with patients about before they're doing genetic testing, thinking about having life insurance in place so that if something comes back, that they've already got it in place and can just keep renewing their policy. So that is a big thing that we talk about with the kind of initial appointment when people are deciding if they want to do this testing. Yeah.
Great. Well, I think that is it.
Great. Thank you guys for those great questions. And I hope everybody has a great night. And we will see you next Wednesday, April 19th at 6 for our next VPH webinar series.